Now we will start the session. A very warm good afternoon to all. At the outset, I would like to thank the KSOS and the scientific committee for giving us this opportunity. I welcome all to our instruction course, Strabismus, a simplified approach for evaluation. Today, we have eminent speakers to discuss the Strabismus basics. Our external faculty is Dr. Shashikant Shetty from Aravinda Hospital. He is working as consultant in pediatric surgery, pediatric ophthalmology and strabismus. His main interest is on nystagmus and its management. The other faculties are Dr. Jisha K and Dr. Padmasri from GMC Kottayam and Dr. Gargi Satish and Dr. Arya from RIO Trivandrum. And I hope this course will be fruitful for all of you. If you have any doubts, you can ask in the last minutes of the session. Now I call upon Dr. Arya, Assistant Professor from RIO, for her topic. Discussion is on basics of strabismus evaluation.
Good afternoon. At the outset, let me thank Dr. Vijayamma Madam for giving this opportunity. My topic is revise the basics of strabismus evaluation. So what are the goals of a basic strabismus evaluation? To find the etiology, to assess the binocular status of the patient, measure the amount of deviation, to diagnose amblyopia, which is very, very important in a strabismus evaluation, and to define a definite plan of management. In the examination part, you have to take a detailed history, including the birth history, family history, and also history of using any spectacles, patches, or any surgeries done in the past. Cycloplegic refraction is very important, without which a strabismus evaluation is incomplete. Fundus examination to rule out any other sensory cause for strabismus. Measurements of deviation, ocular motility examination, as well as the sensory tests. Now, examination of squint consists of assessment of motor status, as well as sensory status. The motor status examination consists of head posture, where we have to look for face turn, head tilt, chin elevation or depression, ocular deviation, extraocular movements, and vergences. Now, where do we get this abnormal head posture? You have to think about a paralytic, restrictive, musculofacial anomalies, A or V pattern producing the HP, nystagmus, refractive errors, undercorrected glasses. Field defects can also produce an abnormal head posture. So in this picture you can see, first is a child with left head tilt having a right esopalsy and right hypertropia, and on the left hand side you can see a child with left face turn having a left lateral rectus palsy. Now this is again a child with nystagmus having a right face turn, since she is having a null zone towards her left side. Now, abnormal head posture can be assessed from around 6 months of age, once a child starts sitting up. And this was a child with left head tilt, and on assessment she was having a tight sternocleidomastoid on the left side, which is a very important non-ocular cause of torticollis. So that also has to be kept in mind. We have to rule out a pseudostrabismus. In the picture you can see the child is having a broad nasal bridge, telecanthus and epicanthal fold, which produces a strabismus appearance. We need only a simple test to differentiate pseudostrabismus from strabismus, that is our cover test. So what are the important light reflex tests in strabismus evaluation? Hirschberg test, Krimsky and Bruckner reflex test. So Hirschberg test, we know it's a very simple test. You shine torch and look for where the pupillary light reflex is falling, and depending upon the position you can grade it accordingly as shown in the slide. The prerequisites are the child should be able to fixate, cooperation of the patient, and the cornea should be clear. In this picture, you can see by Hirschberg test, we can assess whether the patient is having an exotropia. Here also the pupillary reflex is falling in the pupillary margin. Now, Bruckner test is a very simple screening test. For this, you have to shine the light from a direct ophthalmoscope into the eyes of the child at a distance of 1 meter in a dimly lit room. If it is symmetrical, it is normal. Asymmetric reflex is got in cases of refractive error, manifest squint, amblyopia, retinal pathologies, and media opacities. Next, light reflex test is a Krimsky test, where you place the prism in front of the patient's eye, and in Krimsky you place it before the deviated eye, and you make the light reflex exactly fall in the center of the pupil. In modified Krimsky, you place it in front of the normal eye. Now, for the cover test, we need a target. You can use toys also for very small children and an occluder. Here you can see you have to give a accommodative target for the patient and occlude the fixing eye. You can see the movement in the left eye. It is coming from out to in. So a cover test helps us to find out a tropia. Next, you can see in this video, the child is fixing on a target. We are covering the eye. The child is orthophoric. And you can see once you uncover the eye is coming from out to in. So, by the uncover test, we find out a phoria. Now, it is an alternate cover test where you cover the eyes alternatively and you see for the movement of the eyes. So, by the alternate cover test, we bring out the components of both the tropia and phoria. So, what are the prerequisites for this test? The patient should be able to fix it, central fixation, no gross or severe motility defect should be there. And when this test can be fallacious, in markedly subnormal vision or when the patient is blind, severe restriction or limitation of the extraocular movements and eccentric fixation. Now the points to remember when you do a cover-uncover test, it should not be done too slowly, not too fast also. And while recording, you have to estimate its degree, type of deviation, and also the speed of recovery, whether it is good, fair or poor. And by the cover test, you can identify other conditions also like latent nystagmus, pseudotosis, pseudostrabismus, and eccentric fixation. Now, we have to measure how much deviation the patient is having. For that, you have to do the prism bar cover test or the prism test where you can use the loose prisms as well as the prism bar. So what are the prerequisites? Again, the patient should be able to fixate the accommodative target, refractive correction should be worn, and this test can be affected by the refractive error. So in this test, you can see you are doing an alternate cover test. After that, to neutralize it, you are placing prism bar in front of the patient's eyes. And the prism should be placed in such a way that its apex is directed towards the direction of deviation. In the slide, in the video, you can see the child is having an exotropia, and hence the prism is directed with apex outwards. And you increase the power of the prism till there is no movement of the eyes. Now you can see there is no movement of the eyes, and then you record the power. Now deviation should be measured for near as well as distance, with and without glasses in the 9 cardinal positions in up gaze and down gaze, up gaze at 25 and down gaze 35 degree, to differentiate whether there is an AV pattern. If there is a difference of 10, it fits into A, and 15 V pattern. And after prolonged cover test also. Now coming to the extraocular movements, you should record the uniocular movements, ductions, binocular versions and vergence in the 9 gaze positions. So in the video you can see the child is not able to abduct in the left eye. The child was having a lateral rectus palsy. Again the child is looking towards his left side. Abduction is limited in the left eye, and in the next slide you can see that there is a retraction of the globe, narrowing of the palpebral fissure as well as a downshoot on adduction. So this child was having Duane's retraction syndrome. Again in the upward movement, the patient is not able to look upwards. The patient was having an inferior orbital wall fracture with inferior rectus entrapment. And here there is a limitation of elevation in adduction. This was a child with infantile esotropia. You can see the child is looking towards the left. The child is cross-fixating. But on covering the eye, you can notice that the adductions are full. This is a very important test to differentiate it from a congenital lateral rectus palsy. Now convergence you can measure with the RAF ruler. Now what are the subjective tests of ocular deviation? Diplopia charting, where the patient wears a red-green goggles and tells you how he sees the images. The Maddox row test, depending upon the shift of the image, you can diagnose an exophoria or esophoria. Hess charting. And how do you measure the cyclodeviation? You can measure it with the help of a double Maddox rod. Also, you have to identify the fundus torsion, where the fovea will not be corresponding to the midline of both these lines, midpoint of both these lines. Now you have to examine the sensory status, where you assess the binocular status, diplopia, correspondence, suppression, amblyopia, which is very important, and you have to grade the stereopsis. For sensory adaptation, we use a Bagolini glass and diagnose what the child is having. Wirtz Fodor test also the same purpose. Bilshowski's aftermage test, and the special test done in strabismus evaluation, FDT, FGT, EMG, and Tensilon test. Thank you for the patient listening.
Thank you, Adia, for your an excellent talk. She has covered all the points, but in a simplified way, how to evaluate a case of strabismus. And next talk is on demystifying the vertical component in horizontal strabismus. Over to Dr. Jisha.
Thank you, madam. Demystifying the vertical deviations in horizontal strabismus. Uh, Horizontal strabismus is the most common type of strabismus that we encounter in our clinical practice. But when we evaluate for the ocular movements, we see some vertical deviations which makes it very complicated to understand from the perspective of a general ophthalmologist. So the diagnosis of horizontal strabismus with vertical deviation needs a thorough knowledge on the clinical characteristics of each type. I'll be focusing on the evaluation and diagnosis of vertical deviations only. Management will not be addressed in this class. And the evaluation starts with examining the eye, the movements in 9 cardinal positions of gaze, and assessing for the vertical deviation in each position of gaze and addressing the diagnosing the pattern. And at the end of that evaluation in 9 cardinal positions, first category is forced over evaluation in adduction. In this picture, you can see that the first picture is that of left esotropia. When the child is looking to the right position, you can see the left eye is elevating. That is the over elevation in adduction of left eye. And it is diagnostic of inferior oblique overaction. Inferior oblique overaction is seen in 70% of infantile esotropia. It can be seen in other types of acquired esotropia like accommodative esotropia also. And 30% of cases of exotropia can also have inferior oblique overaction. The other features of inferior oblique overaction are that usually congenital esotropia manifests by 4 to 6 months of age, but inferior oblique overaction is delayed presentation after 1 to 6 years of age only. It is mostly bilateral, though it can be asymmetric. And the horizontal strabismus changes in the pattern of V pattern strabismus, that means more of divergence in upgaze. And the most important factor is that even if you operate the horizontal strabismus for infantile esotropia before the age of 1 year, the inferior oblique overaction can have a later presentation. So better to include that also in your consent form and make the parents aware. There are 2 types of inferior oblique overaction. One is a primary one where there is no associated pathology, it is idiopathic. And the secondary variant is due to paralysis of the same eye, ipsilateral superior oblique paralysis or the contralateral superior rectus paralysis. But the paralysis, the paralytic muscle, it may be difficult to identify because the limitation of movement will be very minimal. So how to identify whether the oblique overaction is a primary one or secondary one? The most important diagnostic test is a head tilt test. The vertical deviation, you have to measure the vertical deviation in the primary position by tilting the head to the right and then to the left. If the deviation is more than 5% diopters, it is diagnostic of a secondary inferior oblique overaction. Of course, you can look for other points also, like the pattern of V pattern. It is sort of Y pattern in a primary inferior oblique overaction and an arrow pattern in secondary inferior oblique overaction. And is it the only diagnosis when the eye is over elevating in adduction? No. You can observe the upshoot of Duane's retraction syndrome, but you have to look for you can diagnose Duane's by other features. And a tight lateral rectus muscle due to a long-standing exotropia or an over-resected muscle also can produce an upshoot in adduction. And sometimes you have to know that a DVD, when you are looking for version movements, the adducting eye may be occluded from the target by means of the nasal bridge, and you will get an overshoot of the adducting eye. That is DVD, not inferior oblique overaction. And a vertical displacement of horizontal recti muscle, especially after surgical procedure, can also can mimic an inferior oblique overaction. And the second set of vertical deviations are over depression in adduction. It is taken as superior oblique overaction. And it is mostly seen in exotropia, but it can occur in esotropia also. And the horizontal strabismus, strabismus can have an A pattern with a divergence in down gaze, mostly lambda type subtype of A pattern. And you have to look for, sometimes you will get an elevation restriction or a limitation of elevation in adduction. That is because of the tight or the overacting superior oblique may limit the eye from moving up in adducted position. This is a pattern. And the next vertical movement that we have to think of is the dissociated vertical deviation. And this is a hypertropia which is not obeying the Herring's law of equal innervation. Either eye, you can see that the either eye is slowly drifting upwards and outwards with a simultaneous extorsion. This happens when one eye is occluded or even during periods of inattention. So this girl is having a divergent squint with dissociated vertical deviation. You can see that the vertical deviation in both the eyes is from above down. Both the eyes are coming from above down. This is unlike the hypertropia where when you are doing an alternate cover test, you will see that one eye is moving from above down, the other eye is moving from below up. That is hypertropia. And this is manifest dissociated vertical deviation where you can see that the left eye is spontaneously drifting up and it is coming back. This is manifest. Whereas in latent DVD, the updrift occurs only when you occlude the eye. The eye undercover drifts up. The other features are it can have head tilt and there will not be any diplopia because of absence of binocular single vision, and it will be bilateral. Most of the time it is bilateral, but it is asymmetric. And it can coexist with oblique overactions. The diagnosis becomes very difficult and complicated when it is coexisting with inferior oblique oblique overactions, either superior or inferior. And that may be the reason for incompetence of the vertical movement that you observe with dissociated vertical deviation. And how to differentiate inferior oblique overaction from dissociated vertical deviation? You have to know that the elevation or the upward movement is seen never in abduction in a case of inferior oblique overaction, where in DVD it occurs in all the positions, primary, adduction and abduction, the vertical movement is happening. And V pattern may be associated with inferior oblique overaction, but it is not a feature of dissociated vertical deviation. And you have to closely observe the refixation movement, which is a sudden movement or a fast movement in inferior oblique overaction, whereas for DVD it is a very slow movement. And you might observe on refixation the encycloduction movement may be observed. And another interesting feature that you have to look for is the Bilchowski's graded density filter bar. That this test can be done when you are in doubt. That means when the you have to keep neutral density, increasing density of neutral density bar in front of the fixing eye. And when the light intensity of the fixing eye has been brought down to a particular level, you can see the dissociated eye gradually comes down. And the comitant hyperdeviation is a very small angle of comitant hyperdeviation can occur in 25% of horizontal strabismus, which does not have any impact on your surgical management. So the differential diagnosis the differential diagnosis of various conditions in vertical deviations you have to address, because the diagnosis is important to recover both functional and cosmetic outcome. Thank you.
Thank you, Disha. She has explained the difficult part in strabismus, is the vertical component, in a simplified way. And next is I welcome Dr. Gargi Satish to speak on unfolding the mystery of special strabismus.
Okay, good afternoon all. Thank you so much, Vijayamma madam. Going straight to the topic about special strabismus types, I will just rush through just our favorite types. For the favorite of everyone will be the Duane, because it is very easy to diagnose. Even my JR1s are very happy to see a Duane's because they can easily diagnose the condition. But it has its own intricacies. It comes under the congenital cranial disinnervation disorders. Most cases of Duane's are sporadic, they are unilateral usually, and somehow is seen slightly more in female children. Video. Okay, so this is a case of classic type 1 Duane, and somehow during the embryonal stage, there occurred a problem, and there is a paradoxical innervation of the lateral rectus by the oculomotor nerve, and there is limitation of abduction and the classic co-contraction of LR and MR causing globe retraction and narrowing of palpebral aperture on adduction. So this is a Huber's classification. There are lots of classification, but Huber's based on EMG is what is usually said. This is type 1 Duane, which can be ortho or ESO in the primary position. Now type 2 Duane is very rare, but it still can occur. So you can see in that picture that the right eye is not abducting well. It can abduct nearly fully, but that globe retraction and narrowing of aperture in adduction will remain the same. Also in Duane 3, there will be restriction of both adduction and abduction as seen in the left eye of that patient. The globe retraction and narrowing of palpebral aperture will definitely remain on attempted adduction. Bilateral Duane's is again very rare. It's actually quite a crippling condition when you have, with regards to our binocular field of vision, because there is restricted abduction in both sides. But thankfully it is quite a rare condition. Abnormal head posture very commonly seen, especially if it is a unilateral type of Duane's, and there will be face turn to maintain binocular single vision, and in such cases amblyopia is rare because BSV is maintained. The major cosmetic blemish of Duane's patients are these upshoots and downshoots. So they can be due to a mechanical cause or an innervational cause. So the mechanical cause is because of the very tight LR, which just slips under or over the globe, or vice versa. The globe slips up and down. And this is called the bridle effect or the leash effect, and it is a very sudden sort of movement. Sometimes it can be an innervational reason also, where there is some sort of an abnormal synergistic innervation between the vertical muscles and the MR. So here the movement is slightly more gradual. Now, the management of Duane's, non-surgical, all the measures, and sporadic types, you have to rule out congenital malformations which can all be associated. So, because we can never correct this paradoxical innervation, we defer surgery till it's absolutely needed. And preoperatively, a force reduction test to find out where the maximum restriction of contracture is really required. So if there is significant ocular deviation in primary position, markedly anomalous head posture, disfiguring upshoot, downshoot, retraction, you go in for surgery. So surgical options, it should be an individualized approach. What is the main problem in that patient you address? So the recessions are all performed. You can do medial, bimedial. You can combine medial rectus recession with an LR recession if there is severe co-contraction. You can try transposition, but ideally never go in for a resection. Don't resect the lateral rectus if possible. Then for upshoot, downshoot also, a variety of procedures are available, like Y splitting of LR. If it is an disinnervation, you can do a recession of the vertical muscles. The differential diagnosis has already been mentioned is very important, because if the child is very small, examination of extraocular movements is very tricky. So you should not miss out on an abducent nerve palsy or an infantile ESO, where the follow-up and the implications are totally different. So in a congenital abducent palsy, there will not be a globe retraction. So that globe retraction is very classic, and the amount of deviation is in the primary position is going to be proportional to the abduction restriction. In Duane, the abduction restriction is very great, but in primary it may remain ortho. Similarly, in infantile ESO, you have to somehow see that the eye is abducting and rule out that rule out Duane and abducent palsy. So the DDs are very important. Coming to the next special syndrome, which is Brown's, which is actually not as common as Duane's. Limitation of elevation in adduction due to mechanical restriction of the superior oblique. Again, mostly unilateral, slightly seen more in females. So it could be a congenital Brown's or an acquired Brown's. Congenital Brown's is because of a shortened or inelastic SO tendon or something wrong at the trochlear complex. Acquired is usually inflammatory. It could be a systemic inflammation or a localized inflammation, post-trauma, post-surgery, etc. Abnormal head postures, very common here also. You can have a chin-up, contralateral face turn. And the patients may classically complain of a click or a snap felt in attempted elevation in adduction. So, Browns can be mild if in primary position and in the lateral gaze, the eye is remaining without any deviation, and the problem is arising only in the elevation. If in primary position it's normal, but in the lateral gaze itself, the deviation becomes evident, like in the right eye of the child, it is a moderate Browns. And if it is evident in the primary position, you can call it as a severe type of Browns. So always remember, the elevation is going to be normal in abduction. There won't be any muscle sequelae because it is not a palsy. But you may get a slight overaction of the contralateral superior rectus as seen in the picture. Mostly it causes a V pattern. Again, the FDT is very important. You should all know how to do an FDT on the oblique. And you should know that a retro placement or pushing the globe with the forceps into the orbit will further stretch the already stretched out superior oblique and accentuate the restriction. So this is a classic question of Hess chart in Browns. So the DD is again very important here. The DDs are inferior oblique palsy, where you get an A pattern. FDT will be negative, sequelae will be present, Bielchowski will be positive, and double elevator palsy, where abduction is in abduction also elevation is going to be restricted. So most of the Browns will spontaneously improve over time, and so we opt for surgery only in the severe cases. We can go in for SO weakening procedures, SO expansion procedures. Acquired Browns we manage medically with steroids, local injection or systemically. Just a mention of double elevator palsy, which is actually a misnomer. It is actually a monocular elevation deficiency. Video. Okay, so both in abduction and adduction, the elevation is restricted, and it is basically of the three types mentioned. Could be due to a tight IR, a long-standing SR palsy, or a supranuclear origin. So in adduction it is elevated. In abduction also it is going to be restricted, the elevation. So basically in DEP also the management depends on whether it is paretic or restrictive. And you can do, if it is restrictive, you can do recession along with vertical muscle transposition. So a variety of special conditions causing strabismus. To summarize, each syndrome, you have to diagnose the syndrome. Most importantly, rule out the differential diagnosis. A force reduction test is of immense significance. The surgery is very challenging in these cases. A tailored approach, you have to find out what the maximum problem is and address that particular problem. Thank you so much.
Thank you, Dr. Gagi. You made it very simple and easy to understand. May I invite Dr. Padmashri KM for the next talk, Considerations in Spectacle Prescription and its Use. Over to you, Padma.
Thank you, madam. So now we are on to the management of squint. My topic is spectacle considerations in squint. For a squint case, we have many. Before surgery, we will have to manage them with several non-surgical modalities. I will be stressing upon the optical management and the treatment of amblyopia. How does the optical correction help? It gives us sharp, well-focused retinal image which will help in functional control and also the development of BSV. It also corrects and maintains the relation between accommodation and convergence. So for optical correction, refraction is our first step. Pediatric refraction, as you know, is challenging because of the strong accommodational tone in children. And the eye growth demands repeated refractions also. So the gold standard is a good retinoscopy. If you are using an auto-refraction in school-going children, you should combine it with appropriate cycloplegia. So for our dark iris and small children, it is atropine 1% eye ointment. So to fully relax the accommodation, we have to go for no shortcuts. So atropine 1% ointment, rice green size, twice or thrice daily, for 3 consecutive days preceding the day of refraction should be used. And if you see that in older children, if you have residual variable angle seen after milder cycloplegics, you have to go for an atropine refraction. When they come for retinoscopy, see that the relaxation of accommodation is there. So by doing a dynamic retinoscopy. So our step 2 is a proper prescription. Based on the retinoscopy, you have to fully correct the refractive error in presence of squint. That means only the distance correction need be reduced from the retinoscopy value. And you can prescribe for a preschool children without waiting for post-cycloplegic acceptance. So children in their metropization phase, they will have lot of refractive errors revealed during the retinoscopy, but you need not prescribe all. We have to go, we can go according to the guidelines given by American Academy of Ophthalmology. I would like to highlight hyperopia with esotropia. The correction, threshold is as low as even we have to prescribe 1 point diopters of refractive error. And one more thing that I would highlight is that threshold for correction in anisometropias should be very lower if the child has strabismus. This national consensus statement for our population also confirms the same. So after your prescription, if it is properly fitted in the child, fitter for the child will comfortably wear it. We have to look at the size of the spectacle, which should be big enough to cover eyes in all position of gaze, and the nasal bridge should be broad and comfortable to the child. Ear supports should be comfortable, and that makes sure that the spectacle does not fall forwards and fit in place. The article also gives the recommendation for type of spectacles. They should be lightweight and break resistant. The child should not peek from the sides of the glasses. You can even prescribe for a 3-month-old child. Regular 6 follow-ups for vision and retinoscopy is a must. Coming to exotropia and refractive errors. Myopia is the commonest refractive error associated with exotropia, as you know, because of the poor accommodation. So correct myopia according to the guidelines, because once you correct it, the spectacle stimulates accommodation, it will improve convergence and control of intermittent exotropia. So can we give overcorrections to myopia to control exotropia? But that is questionable. And you can see hypermetropes with exotropia. Why? Because in high hypermetropia, they cannot accommodate to clear the blur for distance. So they can go for exotropia. Moderate hypermetropia also, if you give glasses, that will take away the accommodative effort. So appropriate undercorrections can improve control of exotropia in hypermetropes. Astigmatism, you have to fully correct it in children. Here, this child had -4 diopter cylinder of astigmatism. She has a large angle exotropia for distance and near, and giving her spectacles has improved her near vision control over exotropia. So, an exotropia can be any refractive error. So, you have to find out from retinoscopy and manage accordingly. Coming to esotropia and refractive errors, accommodative esotropia, the effort of accommodation is the culprit. And we have the refractive type and hyperaccommodative type. The refractive type, the hyperopia amounting 2+2, 2+6 diopters may be there. And once you give the correction, you can see that the eyes are straight with the spectacle. So here it is important that you go for a constant wear spectacle correction. And you have to educate the parents that spectacles are only controlling the strabismus, not curing it. So the child has to wear it constantly. Coming to esotropia with high AC by A ratio, here they have abnormal relationship between the accommodation and accommodative convergence. So for near, the esotropia will be larger, and that can be made straight by relaxing the accommodation with a +3 add. Because of time shortage, I am not talking about how to calculate the AC by A ratio. Anyway, if when the child is given a spectacle correction, it should be an executive type of bifocal and the flap top style segment, and the top of the segment should be crossing the pupil. So that makes sure that the child uses the spectacle for all near activities. Step 3 is our amblyopia treatment. The abnormal binocular interaction in strabismus disrupts BSV development and will suppress the deviated eye. So there will be diminution of vision in that eye. That is, you have to, that is amblyopia, and you have to treat amblyopia whenever it is present. So a reliable baseline visual function should be assessed, and the gold standard treatment for amblyopia is correction of refractive error and occlusion of the better eye. It can be given as direct skin patches or as spectacle occluders. Full-time occlusion is total occlusion of the dominant eye alternated with occlusion of the amblyopic eye. The frequency of the patching depends upon the age of the patient. Example, if the child is 2-year-old, it is 2:1. That is 2 days of dominant eye followed by 1 day of amblyopic eye. This kind of occlusion has got the risk of occlusion amblyopia, so you have to carefully follow up. So the amblyopia treatment studies by the Pediatric Eye Disease Investigation Group has tried part-time occlusions. Many trials have been there, and they have found out that in severe and moderate amblyopias, you can even do effective patching with 6 hours or 2 hours. The most important thing is that you have to initiate the treatment as early as possible. So part-time occlusion is better accepted in school-going children, but that hours of patching should be given in a single stretch of time. Spectacles can also be used for prism therapy, but it is not a favored treatment, but it can relieve diplopia in conditions like residual deviations and consecutive deviations. So my take-home message in squint management prior to surgery is that the quality of your non-surgical management reflects the outcome of the surgery. So do all these steps properly. Refraction with proper cycloplegia, prescription whenever there is significant refractive error is there, and give a well-fitting spectacle to see a happy child coming back to you. Detect amblyopia whenever it is there and treat it and do a proper follow-up. These are my references, and thank you for your hearing.
Thank you, Fatma, for that elaborate and excellent talk on prescription, spectacle prescription. Now we have Dr. Shashikant Shetty to talk on decision making in strabismus surgery, a systematic approach. Over to you, sir.
Good afternoon, everyone. I like at the outset I like to thank Dr. Vijayamma for calling me for this great instruction course. I'll be talking on decision. I think most of the speakers have covered all the different type of strabismus. So I'll be just talking on decision making in different type of strabismus. So when we do strabismus surgery, what is our goal? Our goal is to eliminate the relative deviation of the eyes, like compared to both eyes. If the eye is ESO or EXO, so our goal is to reduce the strabismus. So why you want to reduce the strabismus? Why you want to do surgery for the patient's strabismus? So the main goal is to get binocular vision for the patient and to get a 3D vision. And if they have diplopia, we need to eliminate the double vision. And personality and cosmesis also plays a good role. And even if the patient's stereo vision or binocular vision doesn't improve, studies have noted that there's improvement in their binocular fields. Patient can see better now, even if there's no response in their binocular vision. Like they are still suppressing, but they have noted improvement in their binocular fields. So in a child, when you operate, you might, the parents may say the milestones have become better. Child is able to walk better, no? Reach to objects better. So I'll be talking on esotropia, infantile esotropia, partial accommodative esotropia, late onset and paralytic esotropia. So infant is esotropia. What is the age? So patients might ask you, when is the best time to operate this child? As one of the speakers has told that inferior oblique overaction may develop over a period of time after the age of 1 year. So we prefer to operate them by age of 1 year if you are able to measure the deviation. Even dissociated vertical deviation can develop later on after you operate the infantile esotropia. If you read the Adler's physiology of the eye, which states that the binocular vision, the simultaneous perception, fusion and stereo develop within 1 year of age. Okay, so if you operate them early, the chance of developing binocular vision is better. But there is always a risk of not measuring the deviation properly, and later on child developing dissociated vertical deviations. So when you operate, you tell the parents that child might require one more surgery after your initial surgical correction. So the max medial rectus recession, what we do is 7 millimeters for an angle of 60 prism diopters. So we start with maybe 3.5 millimeters medial rectus recession to 7 millimeters is a max, because there's a possibility, if you do more than that, there's a possibility of patient developing consecutive exotropia. So these patients they might have associated infantile nystagmus syndrome, okay, or they may have something called as fusion maldevelopment nystagmus syndrome. I think people will feel sleepy seeing those terminologies. So there is nothing called a latent nystagmus. So patient can have fusion maldevelopment nystagmus, because why it is important is patient may have head posture. If they have a FMNS, they might keep a head posture to keep an adduction null. So they might do like this, and they might bring that eye with a better eye in the adducted position and block the nystagmus. Okay, so when you operate those patients, you will reduce their face turn as well as the esotropia. But if they may have head tilt, so then you have to think of, they might have an idiopathic infantile nystagmus, or they may have a coexisting DVD. So if you correct their esotropia, the head tilt might persist, because we are not treating their INS, or the INS might get better, or you are not treating their dissociated vertical deviation, which will create a head tilt. The head tilt is always towards the side of the fixing eye. Okay, it can be a contralateral head tilt also, but most of the time it's an ipsilateral head tilt towards the dominant eye. That is because of your, when they tilt, they are stimulating their inner ear, the endolymph is stimulated, and that causes stimulation of the vestibular cells, and that stimulates the medial vestibular nerve. And children who have delayed milestones, so those patients, there's always a possibility of those developing, they can develop spontaneous exotropia. From esotropia, they then become exotropic. So in those patients, we can do little less surgical numbers. And we need to add inferior oblique, as the previous slide showed, patients having inferior oblique overaction which can coexist with esotropia. So you need to add inferior oblique surgery. So what we do is, we do a inferior oblique antro-positioning, little bit anterization of the inferior oblique to prevent future DVD from occurring. So that will correct a V pattern as well as the future recurrence of DVD. And as the previous speaker has told about the accommodative esotropia, which can be corrected with glasses. So initially this type of esotropia will usually present by 18 months, because where the child is trying to read, trying to accommodate, and then you will find this patient developing esotropia. So in those patients, we need to treat them initially with glasses, and if there is a non-refractive component with high AC by ratio, then we need to give them bifocals. So first is give the full correction. If the esotropia is persisting for near with a high AC by ratio, then you need to give them bifocal glasses. So as you either give them executive bifocal or D-shaped bifocals with the upper margin of the bifocal bisecting the pupil. And if the esotropia is very significant, AC by ratio is low, so and they are not responding to bifocals, then we need to do a surgical correction for the esotropia. So why we want to operate this esotropia is to get the esotropia towards a very small angle, like to microtropia, very small angle deviation, so the patient develops binocular vision. The whole idea of operating this patient, giving glasses, so that the patient develops binocular vision. We have seen a lot of cases of late onset esotropia recently, which are basically either could be a decompensated esophoria. So they might have a latent deviation and decompensated to esotropia, and it's also common in patients moderate myopes. Prolonged device usage can also cause late onset esotropia. We image all these patients to rule out intracranial cause, and then we need to do an early surgery to prevent suppression. And intermittent exotropia, when we need to operate, that's a very big question. So we avoid surgery if the child is less than 4 years, the possibility of developing consecutive esotropia. And if they have very good control, excellent control, so we don't touch them. We either give them minus lens therapy with small prisms, basin prisms, that helps them to accommodate and then converge and reduce their exodeviation. Or you can also try orthoptic treatment like alternating eye patching. And patients where we need to operate, we do patch test for all patients with exotropia. We do a gradient method AC by ratio for distance. I know it's little on the higher side. And we do a ultra near testing for exotropia. Ultra near testing is what is, we keep the target close to your eyes at 10 centimeters, and then we look for, we do a cover test and look for esophoria. Okay, if they are esophoric and if they have a high AC by ratio for distance, then it is called as true divergence exotropia. And those patients, we have to be very careful when you operate, because they can develop consecutive esotropia. So in those patients, we can give them minus lens therapy as bifocals. You give a bifocal like a high minus at the top, and you give less minus in the down. So that takes care of the exo for distance. And if the deviation is, we call it a pseudo divergence, pseudo AC by ratio, where AC by ratio is more for near, but the gradient method for distance is on the lower side, and they are exophoric for ultra near testing, then we operate those patients. So we can have convergence insufficiency, where we can do a patch test to differentiate between true convergence insufficiency and pseudo convergence insufficiency. So again, true convergency, there are two types, as accommodation and fusional insufficiency. So we treat them by either by glasses or by a slanted resection. And large angle exotropia, if there is more than 50 prism diopters of exotropia, we do 3 muscles. And if it's like 60, 70, we do 4 muscles. And if the patient has got an amblyopia eye with large angle exotropia, we do a muscle transplantation. Fourth nerve palsy, in congenital patients, we operate them early because they will have head tilt, and they can also develop facial asymmetry and degenerative osteoarthritis if we don't treat them early because of the constant head tilt. And if it's acquired palsy, and then we look at their torsion, we look at the side gaze deviations, and we measure their deviation in the primary position, and we do surgery. We can do like superior oblique tuck or multiple procedures to reduce their torsion. See, patients in fourth nerve palsy, especially post-trauma, patients presenting with torsional diplopia, they will not complain of torsion, but they will complain of blurred vision and blurred down vision. They say when you check their vision, they will be N6, but the patient will say they will have little blur. So you need to look at their torsion. So inferior field defects and bilateral uncorrected torsions can cause defective near vision and a constant blur. So you need to do a double Maddox rod and check their torsion. And if you see a child with nystagmus, when we need to intervene surgically, if there is a large head posture, we need to look at the stabilization of the face turn. We wait till the age of 6 years. We try orthoptic management, medical management to reduce their face turn, and then you have different surgical armamentarium to reduce their face turn. We also do eye movement recordings. We do eye movement recordings in patients with nystagmus to look at pan, periodic alternating nystagmus, look at their multiple null points, and there is something called as nystagmus acuity function. So when we correct nystagmus by treatment, we are not just correcting the face turn of the patient. We are actually correcting the different gazes vision of the child, because the child is going to look at different gazes when they can have nystagmus. So that is called as gaze dependent visual acuity. Gaze dependent visual acuity. and there is something called as fovation time, fovation period, which improves when we correct their nystagmus. And in patients with third nerve palsy with aberrant innervations, so in those patients we don't operate their affected eye, we operate their non-affected eye. When we operate the non-affected eye, we create a fixation duress, so we reduce their deviation in the primary position as well as improve their ptosis. So when the patients with, as you can see in this photograph, in that primary position there is a ptosis, and when the patient looks in levo version towards the left gaze, you can see the ptosis getting better. This is inverse Duane sign. So those patients who have this inverse Duane sign, we don't operate the eye with the third nerve palsy, we operate the other eye. As madam is told about the double elevator palsy, when we see a patient with double elevator palsy, look at their chin elevation. Always look for binocularity in the down gaze. That is very important. If the patient is binocular, then you don't need to touch their inferior rectus, because then you're going to create double vision in the down gaze. And look for dissociated torsional deviation in patients with double elevator palsy, because many of these patients can have coexisting DVD, and if you operate this patient, then there's a possibility of them developing consecutive hyperdeviation. If the angle is 30 PD with a negative FDT, then we do a modified NAPS. And when you are doing an inferior rectus surgery in any patient, you have to be very careful, because a late slippage can occur, because inferior rectus has got a very short arc of contact, and the inferior rectus has a adipose tissue which is behind it, and it prevents the inferior rectus from getting attached to the globe. And there's a constant Bell's phenomena which prevents the inferior rectus from getting attached to the globe, causing an inferior rectus slippage. So that is a very important gaze, and the patient's got binocularity in the down gaze, and you're going to do inferior rectus surgery, then you have to be very careful. Duane's retraction syndrome, as the previous speaker has told, and this is a patient who had ESO Duane's, already undergone surgery, had a residual esotropia. So we did a modified Nishida's procedure, where you do no split, no tenotomy procedure, and it corrected the deviation very well in the primary position. And this is a patient with bilateral 6 nerve palsy, where we did bilateral medial rectus recession with Nishida's procedure. So points to ponder. So when you see a patient with strabismus, always do an indirect. To rule out, look for retinal holes, because patient might say that after your surgery the retinal hole has developed. So look for retinal holes, do a careful indirect, look for retinal holes. At the same time, look for torsion in the fundus. So that will give you a lot of clue whether there's a coexisting oblique dysfunction. Look for conjunctival scarring. Sometimes patient may not give you a history that he was operated in the earlier age. So when you're doing a anterior segment examination, look very carefully for conjunctival scarring suggestive of old strabismus surgery, or they might have old retinal detachment surgery, which can also induce strabismus. FAT scan. What is FAT scan? Can anyone tell? Excellent. Family album tomography, that will help us to tell what type of deviation patient had. Sometimes you can have a spontaneous consecutive exotropia. Patient might be isotropic. You look at his old photographs, he might be isotropic. And patient, you ask him what happened. He said, no, I have not undergone any surgery. Anterior segment is fine. So they can develop something called a spontaneous consecutive exotropia. From ESO, they might become EXO. Look for bleeding disorders. Ask history of bleeding disorders. Patient might have had history of previous bleed, which we might think may not be important. Patient can bleed during surgeries. So look for bleeding disorders. Check for fusion. Check for fusion. If look whether the patient is able to fuse. If the patient is not fusing, then he might be a risky patient. Then you have to look for other findings, like look for anisometropia. Look for anisometropia. Look for uncorrected torsion. And post-operatively, careful about anterior segment ischemia. Patients who are smokers, they are very prone for developing anterior segment ischemia. So to be very careful, carefully look for anterior segment findings. And your surgical numbers will depend on your experience, like how much you've done previously and what is the numbers you're getting. That will depend on your experience. Thank you.
Thank you very much, sir. It was loaded with information for us. Can we take questions? Any doubts?
Sir, when we have children with nystagmus and squint, some will have no head posture change or face turn. How do you know that it is due to nystagmus or due to strabismus?
So you are saying that patient is having head posture. This is a very excellent question. So madam wants to know if the patient is having head posture and you're not sure whether it's because of the strabismus or it's because of the nystagmus. So then you need to occlude one eye and then again check for the head posture. If the patient is keeping head posture even with the one eye closed, then you have to suspect it is due to nystagmus. And if it's due to strabismus, then the head posture will get better. One is you close one eye and then you close the other eye, and also you need to close both eyes. What you're looking for? If the patient has got any cervical related problem like cervical dystonias, or patient is having tight sternocleidomastoid muscle, so patient will keep head posture whether you close both his eyes or close one of his eyes. So close one eye and close both eyes and they look for the head postures.
Sternocleidomastoid contracture due to
Then you need to release this. That is also called a sternocleidomastoid tumor, according to Dr. Brodsky. And then you need to screen, do an MRI, and then look for the muscle, this thing, on the MRI scan.
Sir, how do you address for the lateral incompetence in horizontal deviations? Exotropia?
Lateral incompetence, according to Dr. Kushner, he feels that it may be because of the tight medial rectus in a patient with intermittent eczema, which is a paradox. Actually, the medial rectus should be lax, but he feels that it's because of the tight medial rectus, which causes incompetence in the lateral gaze. So when you're checking lateral incompetence, according to Dr. I forgot his name. So what he has devised is you have to make a patient turn the head 30 degree. Okay, make the patient turn the head 30 degree, and you have to keep the prism in the adducted eye, not in the abducted eye, and then you have to measure the deviation for distance to look for lateral incompetence. But if patient has already undergone surgery like lateral rectus recession, so that is going to create because it's already undergone surgery, so you might find a lateral incompetence in those patients. So that is not lateral incompetence. In patients who have exotropia, I find it's an artifact, more of an artifact. So I don't believe that lateral incompetence exists.
Thank you, sir.
Any other doubts to be clarified? Thank you very much.
Sir, actually, it's about dissociated deviations. In another talk, I heard like there are people are attempting inferior rectus plications for unilateral DVDs. What's your experience in that, sir? Even in patients with inferior oblique overactions.
But no, you have to look for the measurement of the DVD. So you have to look whether it's an incompettent DVD or it's an asymmetrical DVD. But inferior rectus should be the last to be touched, because inferior rectus is a never foregoing muscle. So it is always better to keep it as the last. Like you have done last superior rectus recession, and patient still has a persistent DVD, and is very cosmetically visible, then I think the inferior rectus plication or inferior rectus, because you might have done lateral rectus or medial rectus with superior rectus recession, you can do 3 muscles at one go. It doesn't cause anti-segment ischemia. because the lateral ciliary artery, the posterior ciliary artery, they actually run the two posterior ciliary arteries, so they run horizontally, and so you have an extra blood supply coming from the posterior ciliary artery. So the anterior ciliary artery, which is the muscular branches which forms the goes from the muscle and pierces the sclera and forms the major arterial circle, so there is always a less risk of anterior segment ischemia unless patient has got bleeding diathesis or history of sickle cell anemia. So then those patients are risky patients for anterior segment ischemia. So lateral rectus plication is like you have to do a vessel sparing inferior rectus plication. Like after you done surgery for the DVD, then you can plan for inferior rectus plication, vessel sparing inferior rectus plication.
So one more question was there. In patients when we are planning the modified Nishida, like in LR palsy, whether moving it more close to the LR gives the more effect. Like what's your
Yeah, I
test?
think it should move. We should move the depending on the amount of deviation what you are having. If the deviation is large, then you have to move very close to the lateral rectus. Means around 2 mm from the lateral rectus you have to move the insertion. If the angle is small, then you have to maybe midway you can attach it. But there is no hard and fast rule saying that if you attach here, because I think it is a self-adjusting procedure. Maybe over a period of time it will adjust itself. Patient may develop consecutive exo immediately post surgery, but I think they might adjust it over a period of time.
Is there any cutoff value for that, sir? Like if you are planning to keep it near to the
No,
LR?
there is. That is what I'm saying. There is no
No
cutoff
cutoff.
value. So there is nothing like if you have a 30 PD and you do a modified Nishidas. So it. I think whatever surgery you do, it will just self-adjust over a period of time.
Okay, thanks.
Sir, what's your experience with plication? Are you doing everything plication or
No,
resection
no.
still?
We don't do plication. We rarely do plication. As I told you, if there is like we have done 3 muscles and then we are touching the 4th muscle, then we do plication. Otherwise, we don't do plication. Only we can do plication for superior oblique muscle, but not for squints. Like or you can, if you think that patient may develop like a DVD and you are doing a instead of resection, then you can plan. Like you have to think in advance. Okay, this patient might develop DVD, and then I need to touch his superior rectus. So then I do application now, so that I can do a superior rectus. Like means then it will be you will be still safe to play around.
Thank you, sir.
May I request you, sir, to accept a memento as a token of